All right, welcome back to another audio lecture. In this lecture, we're going to discuss coronary artery disease. And so you're going to see this abbreviated oftentimes as CAD. And coronary artery disease is very similar to peripheral vascular disease. So if you haven't listened to that lecture, go ahead and listen to that lecture before you start this one. And so peripheral vascular disease and coronary artery disease have a lot in common, except coronary artery disease is occurring in the coronary arteries rather than the peripheral arteries or peripheral vasculature. And so this is again going to be primarily due to atherosclerotic plaques building inside the coronary arteries. Now remember, as these plaques form, what they are doing is impeding blood flow, and they are increasing the resistance to blood flow to the tissues that they're delivering blood flow to and oxygen. Now, since these are in the heart, these are going to, if plaques develop and atherosclerotic plaques specifically develop, we can see that the myocardium is affected. And if the myocardium is affected, that is it's not good, because now we can start to impair cardiac work and the contractility of the heart. So we see that the decrease in blood flow eventually decreases oxygen to such a demand that it ends up causing damage to the myocardium. Now, this damage can be variable depending on the severity of the coronary artery disease and how many of the coronary arteries are blocked and how much it is blocked, right? So if it is a big blockage, it's going to cause more damage, and if it's upstream, depending on where it's occurring in the artery, is going to impact more or less myocardium. This is the largest cause of death in the United States. Still, even with all the advancements we've made, we can't figure out how to live a maybe more correct lifestyle. And so we see that the heart, where this occurs in the heart, is differentially affected. And so the left ventricle is most susceptible because it is really the most active. It generates the highest pressure, and so it requires more ATP because you have more sarcomeres actually working. And so we have more vascularization of the left ventricle, the left anterior descending coronary artery, also known as LAD, is also called the widowmaker, right? So if you get a blockage in the LAD, then you can end up seeing really death as a result of that. If the coronary blockage is so severe. So the oxygen delivery to the tissue does not meet the demands, and so we know that as tissues do work, they require oxygen because they consume ATP, and so as the heart is working, it is producing metabolic waste byproducts, and now the blood flow to that area, not only does it have a lack in oxygen, but it also has an accumulation of waste products like lactic acid, carbon dioxide, ADP, and inorganic phosphate, and all these things could end up affecting the function of the myocardium. Now, we'll talk more about this when we get to myocardial infarction, but angina could result, right? So angina is chest pain that originates from the heart, right? From the nerves in your heart being starved of oxygen, right? So, and if they get starved of oxygen, well, then you get nerve dysfunction, and you get action potentials being sent, and then you get this hyperstimulation, and we interpret that as pain. So we have a couple different forms of angina, and so we have stable angina, and this is just due to a decreased blood flow to the myocardium, causing chest pain. Okay, so the plaque is present, and it is causing a decrease in blood flow, and it is induced by activity. Okay, so if you stop exercising, then you oftentimes see a reduction in this stable angina, meaning it kind of goes away for a period of time. So we have unstable angina here. Unstable angina is going to be a series of uncontrolled events. So First and foremost, this begins with an ulcerated plaque. And so ulcerated just means it breaks open or it breaks apart. And these plaques, as they open up, they create sticky edges. And then as the sticky edges stick into the middle of the vessel, or as cell platelets are flowing over the ulcerated plaque, then we could get inflammation occurring. But really, what's going to happen is platelet aggregation. So these platelets, when they encounter rough surfaces begin to stick to them. And as they stick to them, as inflammation is increasing, now the platelets are being activated, and then the activation of platelets causes thrombus formation, right? So as platelets begin sticking to each other, they form a clot, and so this clot could in turn causing thromboxane A2 secretion from platelets in the local tissues. And this thromboxane A2 secretion causes vasospasms. So vasospasm, remember, this is going to be an uncontrolled vasoconstriction of this artery. So we're not intending for this to happen. It's not being controlled by local factors. And so as this thromboxane A2 secretion occurs, then it starts to repeat. And so it's going to increase the inflammatory response. We're going to get more of the white blood cells. We're going to get more platelets aggregating to the surface of the coronary artery, more thrombus formation, and more A2 secretion. And so we have a vicious positive feedback cycle where this negative cycle that is happening just continues to repeat. Okay. And this is known as the pre-infarction state, right? And so this is usually an indicator that you are going to develop a myocardial infarction, which we will talk about in a later lecture. So, like I just said, this can cause a myocardial infarction, which can result in pretty big effects, right? So heart failure, sudden death are the two worst here. Dysrhythmia is bad because that creates an abnormal electrocardiogram and electrical signals being generated with the heart, and if that's not coordinated, then we get some dysfunction there. But really, the two big things are going to be heart failure and sudden death. What are the manifestations? Well, angina, obviously, because that was one of the main things about this is we had angina, either stable or unstable, and this would take further diagnosis to be able to figure out what type of angina we have here. Angina is oftentimes confused with indigestion or heartburn because you get this burning sensation right about there at the connection between the esophagus and the stomach. So indigestion is indigestion is caused by the acid from the stomach coming up into contact with the esophagus. So it can be caused by eating and laying down after too soon of eating. But this is generally a lot more painful than indigestion. We can see nausea and vomiting, cool and clammy extremities. So people who have coronary artery disease often feel cool to the touch. Their skin feels clammy. And sometimes they will begin to sweat a lot, so that is diaphoresis, and so they might sweat quite a bit even though it's not hot out. And then fatigue, right? So anytime perfusion of the heart is going to be affected, we're going to get a decrease in cardiac activity. How do you diagnose coronary artery disease? First, take a medical history. Okay. What kind of lifestyle have they lived? How long have they smoked? How often do they drink? How much exercise do they get? What kind of diet do they have? Are they overweight? You're going to do a physical exam. Okay, you're going to look at the contributing factors like lifestyle choices. You might, to try to get the angina, you might do an exercise stress test in which you put the person on a treadmill or an exercise bike. You have them exercise to their maximal capacity, and then you're looking. Usually, you have them hooked up to an ECG at the same time. You're measuring ventilation rate. You're taking all sorts of measurements to look at the cardiac tissue to see if you can get this right. This is obviously being monitored by medical professionals. And then you would use some sort of imaging technique like echocardiogram to actually visualize the heart, visualize the coronary arteries. You might even use an angiogram. So how do you treat it? We really want to treat this by preventing it from getting worse. Okay. And so the same treatments for atherosclerotic plaques and dyslipidemia are going to be used to treat coronary artery disease, because dyslipidemia and atherosclerosis are heavily associated with coronary artery disease, just like they were in peripheral vascular disease. Um, make better lifestyle choices. Try to take care of your body a little bit better. Lose weight, manage your diabetes, reduce stress. Okay. Pharmacological techniques tools might incorporate nitrates, and nitrates are going to be vasodilators essentially. So what our goal there is to promote vasodilation of the coronary arteries to prevent vasoconstriction, reducing flow more so than others. Beta blockers, we've already talked about those in depth. Calcium channel blockers, we've talked about these in depth. So you should know how each pharmacological tool would be used in this case. And then if we have impaired oxygen transport, like you see in anemia, then we might expose the individual to oxygen therapy, meaning they are walking around with a little oxygen pump surrounding them, right? So anytime I go to the store, I end up seeing an older individual with an oxygen pump and hoses going up their nose. And this could be due to coronary artery disease, or it could be due to impaired pulmonary function. All right, so that is the end of our lecture over coronary artery disease. I encourage you to reference the textbook and all this. Keep on using your textbook. And until next time.